Hi guys, welcome to our gross anatomy lecture. Today we are going to talk about the radius and the ulnar osteology. These are two important bones that form the framework of your forearm. The radius being lateral, the ulnar being medial. The two bones they are joined by an interosseous membrane, which is a very important membrane when it comes to the fracture because when the radius, when the ulna is fractured, the radius act as a splint. All right. So let's take a look at the radius. So the radius bone, proximally, it has a head. This head is concave and circular, right? It actually articulates above with the capitulum, the convex capitulum of the humerus, and then medially it articulates with the ulna via the proximal radial ulnar joint. So you can actually see on the ulna here there is a radial notch that accommodates the head of the radius. Below the head there is a constriction which is called the neck. Um, and remember, this is a very important point because when we did the content of the cubital fossa, we say the brachial artery bifurcate at the level of the head, of the neck, of the radius. Right. The radius in cross section, it's actually going to be triangular in shape, right? Triangular in shape. So it has an anterior border and a posterior border with anterior surface, lateral surface, and medial surface. So what is important to take note of the medial surface of the radius, because the medial surface of the radius is quite sharp and it's also called the interosseous border. That's where there is attachment for the interosseous membrane. Take note of this. Below the neck, medially, you're going to have what you call the bicipital tuberosity or the radial tuberosity. This is an important point for the insertion of the bicipital brachii, the bicep brachii. Remember the bicep brachii originating with the two heads, the long head originating from the supraglenoid tubercle, and the short head originating from the coracoid process of the scapula, forms the belly, and then its insertion is on the radial tuberosity. It's actually very important to understand that when it inserts on the radial tuberosity, it sends an upper neurosis medial that will actually attach the deep fascia, which is called the bicipital aponeurosis. Right, and we also have this famous oblique line, which is an important line also for attachment of certain muscles. Right, on the lateral aspect of the radius, you're going to have what called the pronator tuberosity. In fact, it's the pronator tubercle. If you remember very well, as we're going to dive deep into the anterior compartment of the forearm, there is a muscle called the pronator that actually has two heads and it inserts on the lateral shaft of the radius. Take note of this. As you go from proximal to distal, the radial bone increases in size. It becomes broader and more and increase in bone density, right? So it actually increases, and you're going to find at the distal portion of the radius is actually going to form what's called the wrist joint. Take note of this. The ulna does not form the wrist joint. The wrist joint is formed by the radius. So the distal portion of the radius will articulate with the scaphoid and the lunate, forming the wrist joint. Whereas the distal portion of the ulna, which is the head of the ulna, will actually be separated from the wrist joint by an articulate by an articulate disc. Right. So distally, you're going to have at the lateral portion of the distal portion of the radius, you're going to have um, a radial styloid process. So there's a styloid process, and medially, take note of this. Medial to this styloid process, is actually going to be grooved um, by the extensor pollicis longus, the extensor pollicis longus, which is the extensor pollicis longus that forms the medial border of the anatomical snuff box. You understand? And then medially on the distal portion of the radius, you're actually going to have an ulnar notch that accommodates the head of the ulnar. Right. So that's everything when it comes to the osteology of the radius. Now let's take a look at the osteology of the ulnar. What is very important, the ulnar, it is a posterior border. All right, let me start with this. In cross section, it's triangular in shape, posterior border, and an anterior border. Right, and the posterior border of the ulnar is actually subcutaneous along its entire length. So you can actually feel the ulnar along its entire length. That's very true. So it has a proximal portion and a distal portion. And take note of this, the ulnar, it tapers as it goes distally. The radius widens as it goes distally. That's very important. The ulnar is medial. So the lateral border of the ulnar is quite sharp because it also forms the attachment of the interosseous membrane right here. Right. So the proximal portion of the ulnar, you are going to have this projection called the olecranon, which forms the prominency of the elbow joint. It is the olecranon that is accommodated in the olecranon fossa of the distal portion of the humerus. You remember that? Good. And you're going to have what you call a trochlear notch. A trochlear notch, it actually accommodates the trochlear portion of the humerus, forming the elbow joint. Forming the elbow joint. Right. Behind the trochlea, just below the trochlea, you're going to have a prominence, which is called a process, which is called a coracoid process. And below that process, there's going to be an important tuberosity called an ulnar tuberosity. That ulnar tuberosity, it facilitates the attachment of the of the brachialis muscle. Remember the brachialis muscle that originates mid half of the shaft of the humerus and inserts on the ulnar? Yes, it actually inserts on this region. That's the tuberosity of the ulnar. This is a very important muscle because it forms the medial floor of the cubital fossa. All right. So the shaft of the ulnar in cross section is triangular, like we said, and is actually going to be the posterior portion of it's actually going to be subcutaneous along its entire length. Distally, the ulnar is going to distally and more medially, you're going to have an ulnar styloid process. So this ulnar styloid process is actually larger than the radial styloid process. A very important point to take note. And the portion of the distal ulna is called the head of the ulna. So the head of the ulna actually forms what called the distal radial ulnar joint, which we are going to talk about. And the ulna does not form the wrist joint. Rather, it is separated by an articular disc. You can actually see this is an articular disc. Yes. So this is what we call a distal radial ulnar joint. This is what we call a proximal radial ulnar joint. You can actually see this annular ligament, which we're going to talk about. Now, let's take a look at the interosseous membrane. So the interosseous membrane, it actually, the fibers, what is important about the interosseous membrane, the fibers of the interosseous membrane, they run obliquely downward and to the medial. You can actually see downward to the medial, downward to the medial, downward to the medial. It is actually a very important orientation, and actually opposite to the interosseous membrane between the tibia and the fibula of the portion of the leg. We shall look at it in lower limb. Right. So you can actually see um, this is the proximal portion of the ulna. This is the proximal portion of the radius, right? So you actually have this what you call the dorsal tubercle, and medial to the dorsal tubercle, you can see this groove that is formed by the extensor pollicis longus, which will form the medial border of the anatomical snuff box. You understand? And this is your distal radial ulnar joint, which we're going to look at as we're going to do the joints of the forearm. Right. So let's take a look at some clinical correlates regarding the radius and the ulna. Right. So the first clinical correlate that we are going to talk about definitely is the Colles fracture. So the Colles fracture is actually the dislocation um, of the fracture of the distal end of the radius, which results in from a fall on the outstretched hand. When someone fall on the outstretched hand, is more likely to have a fracture on the distal portion of the radius. Right. So take note of this. This Colles fracture, it's actually common. Is the most common fracture in the forearm and mainly common in women that are above 50 years old. Why? Because of osteoporosis. Remember, due to menopause, there's going to be a decrease in the estrogen concentration hormone, and that can lead to osteoporosis, right? So you are going to actually have the distal portion of the hand, right? Is actually going to be posterior and superior, right? So so if you look like a hump like this, so this Colles fracture is also called the dinner fork deformity. The dinner fork deformity, because when this portion is about 2 centimeters below above the distal portion of the humerus, this fracture happens. The posterior portion, the distal portion of the humerus and the hand, they are going to move posteriorly and superiorly, forming this dinner fork uh, deformity. So it's actually very important because it is the most common fracture, right, of the forearm. Right. So depending on how the patient is fallen, if the patient is going to fall on an outstretched hand, is more likely to have the Colles fracture. But if the patient is going to fall, right, from on the back of the hand, on the back of the hand, right, you're actually going to have the opposite of Colles fracture, where you have the distal portion being anteriorly placed anteriorly, right? That is what you call Smith's fracture. So Smith's fracture is due to a fall on the back of the hand. Colles fracture is due to the fall on the hand. So that's everything that I have for you today. I hope you liked this lecture. Thank you so much and see you next time. Take care.